Good morning, everybody. Welcome to another Surgery Live. I'm Dave Rosen. Very excited for today's session. We have Dr. Gifty Kwakye from University of Michigan, who's going to be talking to us about the pelvic floor. So, Gifty, I'll give it over to you.
Hi, good morning. Thank you, Dr. Rosen. Can you hear me okay? I think there's a little bit of an echo. I think it's gone. So thank you, Dr. Rosen, for inviting me to present on Surgery Live today. My name is Gifty Kwakye. I'm one of 6 colorectal surgeons here at University of Michigan, a few of who are on the call today, including my partner, Dr. Lily McGuire, who's in the office here with me. Together, Dr. McGuire and I serve on a multidisciplinary team here at Michigan that caters to patients with pelvic floor disorders called the Michigan Bowel Control Program. So I know it's pretty early in most of the places you live, so I just want to say a special thank you for making the time to join us, especially Dr. Stan Goldberg, the godfather of colorectal surgery, who is on the call today. I know this is a pretty exciting case. I had titled it Pelvic Floor Conundrums, but I realize not everyone is as excited about pelvic floor disorders as Dr. McGuire and I are. And I guess that's why the organizers decided to change the name from Pelvic Floor Conundrums to Pelvic Floor or Pelvic Bore, solving the most frustrating colorectal issues. But they are right. These are definitely some of the most frustrating disease processes that we manage as colorectal surgeons. And I currently have 6 patients very similar to the case I'll be presenting today that I hope to get your collective guidance on how to manage them. So I have no disclosures. Next slide. So this is a 63-year-old female who was sent to see me by one of our GI specialists in the Michigan Bowel Control Program. They had been seeing this lady for about a year and a half, primarily for her constipation symptoms, and they had tried a bunch of things. The issue was that she also had fecal incontinence. So each time they would make a recommendation on a motility agent, she wouldn't follow through because she would keep on having this drainage. When I saw her, she reported that she was having about 2 bowel movements per week. Typically, she would take a ton of Miralax, Dulcolax, and some fiber before being able to go to the bathroom. When she did go to the bathroom, she reported a lot of straining. She had the sensation that she wasn't completely emptying. So she would spend close to about 2 hours each time she went trying to evacuate everything. Her main complaint was that she had this constant leakage, for which she had to wear a Depends pad or diaper. This was affecting her quality of life significantly. She didn't like the odor. She didn't know when she would have a significant accident. So it was affecting her ability to socialize. Between bowel movements, she would have a lot of abdominal pain and bloating. She noted that she had had 2 prior vaginal deliveries with episiotomies. She denied having any blood per rectum, no weight loss. She had had a colonoscopy, which was normal 5 years prior to seeing me. So this is the rest of her history presented here. She had hypothyroidism, for which she was taking a special thyroid medication. Her TSH had been checked recently and it was normal. The other notable history was a bladder sling operation in 2019 by our urogynecology colleagues. This had been complicated by an abscess for which she needed 5 debridements. 3 of these were done externally and 2 required a transabdominal approach. She had also had a TAH, BSO, and a hip replacement, but wasn't on any significant narcotics. Next slide. So in physical exam, which was done in the prone jackknife position, nothing really notable externally. She had a little bit of stool staining, no significant external lesions or hemorrhoids that I could appreciate. On digital rectal exam, she did have a decreased resting sphincter tone. When you asked her to squeeze, she could augment a little bit, but not too much, and mainly contracted her glutes. I tugged on her levator muscles and there was no tenderness there. I did have her do a commode exam in clinic. With Valsalva, there was no prolapse of any rectal tissue or hemorrhoidal tissue. She did have some mucosal discharge from her anus and a small amount of urinary incontinence. So we have a poll, and I was hoping that we could release that now and then open it up to discussion. Dr. Rosen?
Yeah, Steve, you could pull the poll. Everyone will see the poll on the right side of your screen, and then you can decide what you would recommend next. Do we want to do some more medical management? Is there a referral for pelvic floor PT? Do we need more information? See what everyone thinks, and we'll then have a little bit of a discussion here. All right, so of the 12 people answered, and 11 want more info and want the pelvic floor testing. One person would refer for pelvic floor physical therapy. And since we're all surgeons, no one wants to do anything with medical management. So Gifty. So this is a common type of patient that we all see, right? They come in, they've tried multiple different regimens. It's very frustrating. The patient's frustrated. We're frustrated as clinicians to try to make them better. And then the question is, what do we do? This patient obviously has some degree of pelvic floor dysfunction. And we're gonna, I think from the poll, it seems like most people would get some more information. We'll have that here in a second. But before we do this, Dr. Makel, I'd like to ask you, how do you approach this general patient? These patients come in, they're frustrated often, they're really fed up, they get bounced from patient to patient. How do you go about, setting their concerns at ease and ensure them that you're gonna do your best to try to find an answer for them?
Yes, great question, Gifty. It's a great case because, like Dr. Rosen said, it's common, and we see these patients all the time. And to be perfectly honest with you, outside of our field, I don't think there are a lot of doctors who understand this and can really help patients go down the pathway towards success. So I guess the first thing is that on the digital examination, the question that I have is what happens when the patient strains? And I get most of my information from that. Does the pubic relax? Does the pelvic floor descend? Because the history that you're giving sounds a lot like overflow incontinence, and as though the patient's not completely evacuating. And it sounds like the pelvic floor dysfunction is a primary issue, and that this, at some point, gathering more information, getting a balloon expulsion test, and then hopefully going down the pathways of physical therapy and biofeedback is going to help the patient. But I get a lot of information from that aspect of the exam in the office, and it helps me to counsel the patient, to answer your question about how likely I think we'll be successful in helping.
And there's so many options that can dictate your management. How do you, or Dr. Steele, do you get into the weeds of well, if this happens, then we might be talking about physical therapy, or we might be talking about, are there any injections? Is there sacral nerve stimulation? There's so many different ways you can go. Do you approach that right in the beginning? Do you say, we got to get some more information? I find a lot of times these patients have done a lot of research because they've had this problem for a while, and they are fairly knowledgeable. How much do you set the scene in the beginning, or do you wait for more information?
Yeah, thanks. And first of all, it's great to see so many great, outstanding friends and friendly faces on all together at once. Scott Regenbogen in your office. I haven't had an opportunity to ever see it. Looks good. Gifty, good to see you. I was very pleased first to say, good to see you examine him in prone jackknife position. I know where Lily trained. I can tell you that much. Yeah, you know what? I think this is all about managing expectations. A lot of these patients are frustrated. They've seen multiple providers. They kind of get kicked around to GI, to family practitioner, or maybe they're gynecologists, and then they come to us. So I try to go into that stuff a little bit. I mean, truth be told, I'm blessed because a lot of these guys go to Sarah, and she takes care of it, and I'm sure she's going to weigh in a little bit more. And but yeah, I try to be able to say, listen, maybe this, and set the pathways. Choose your own adventure. If you have this, we're going to potentially go that. If that doesn't work, we're going to go to that, so that they see multiple steps ahead. And then just to roll with time, I just got to say, let's do a little bit better on the polling out there. 12 people out of 54 participants plus. Come on, let's rank this up a little bit. But good case. Good case.
All right, let's go back to the case and let's see what you did next. I think Gifty agreed with the polling of getting some more testing. So let's do that, and then let's see where we go.
Absolutely. So I did go for more testing. And since we train at Minnesota, we were very fortunate to have an experience where they have a pelvic floor center, which has all these testing. It's a one-stop experience for the patients, and they come in and have everything done in one day. Unfortunately for us here, we don't have that same setup. And so we do send our patients out to multiple locations, and that causes some delays there. The easiest thing for us to get are 2 particular tests, but I will discuss that after we do our next section. So these are like all the various tests that you can get. I threw in colon transit study, which is not really a pelvic floor test, but in this patient who's presenting with some of these symptoms, I thought we could discuss, instead of putting it into a poll fashion, what sort of tests you typically get when you're evaluating a patient who presents with these symptoms.
Yeah, I think let's keep going rather than discuss the utility, so we can start talking about the results and how we can help this patient.
Okay, sounds good. So we usually default to, typically by the time they come to see us, they've already gotten a colon transit study, so they know there's no real slow transit that's contributing to their symptoms. And then we usually will get a defecography and an anorectal manometry with a balloon expulsion test. Those are the 2 that we would get here. If the history was suspicious enough that we thought there was some sphincter damage, we would get an anorectal ultrasound, but that sometimes is difficult to obtain where we sort of practice. So this was the patient's anorectal manometry results. I've included the results on the left side, and then on the right side are the normal values. And I know it's a little bit smaller there, mainly for a reference for people who are not used to seeing these test results. And in blue, I've sort of highlighted the things that were abnormal on her test. And you can see it's basically almost everything she has an issue with. Wanted to open this to discussion to see what people think about this result. What do you take away from it? What's a problem? Are you going to do anything different?
Okay, so just to kind of highlight a few things we're seeing, there's a lot of, obviously, when we get these interpretation of these results, there's lots of different things. You can see there is some inconsistencies in the, that's telling us kind of different things. So, for example, the simulated defecation measures that you had there talked about some dyssynergia, but she was able to evacuate the balloon pretty promptly. Dr. Vogler, is this a common situation that you get where you get conflicting results from these tests? And as if this problem wasn't frustrating enough, now we don't have the tests that are telling us the answer as to what's going on.
Thanks, Dave. That was very perceptive of you. But Gifty, good case. This comes across, I don't know, 5, 6, 7 times a week. But it is fairly normal to have some of the tests show conflicting things. So what you're getting at is that they were able to evacuate the balloon promptly. I don't still have it on my screen, but seemed like that was pretty easy to do. But then they had the dyssynergia when you were simulating defecation, I believe, somewhat like an EMG recruitment study. So those 2 things conflicting are difficult, because if they can get the balloon out easily, you wonder why they're showing that their muscles are confused. So that's where, going back to what Justin said, doing a digital rectal exam and asking them to push will start to give you a hint as to which way you're going there. Sometimes you can see a fake out on that dyssynergia if they have a lot of prolapse coming down, especially if you're doing it based on an EMG recruitment. So you'll see a spike in pressures when you ask them to strain, but that's mostly prolapse coming down, maybe not your muscles being confused. And in those cases, they'd obviously be able to push the balloon out since they can push their rectum out. So I think when you have that discrepancy, you either you can rely on your physical exam, or you can go on to a defecography also to actually see what's happening in their pelvis.
So, Gifty, when you were looking at this, anything that jumped out at you that you wanted to, what was your kind of next step? Why don't you take us through, now that you've got some information that tells us, there's definitely pelvic floor dysfunction, and then what are you going to do next to help further figure out exactly how to help this patient?
Yeah, so usually, I think as Dr. Vogler mentioned, the tests can be inconsistent at times. So I usually don't make a decision based on one single test. I usually will have like 2 tests. And so I typically will get a defecography also. And I think that's what we automatically do. We order both studies when we see these patients. So I did go with the defecography. What I took from this was based on her squeeze duration, her maximum squeeze pressure, those are all weak. You definitely see that she has some defect in both her internal and in her external sphincters in terms of how that's working. She also clearly has some issues with the pelvic floor in general, and that's the dyssynergia that they're picking up on. So you have the pelvic floor dyssynergia. There's something going on with her sphincter muscles. We do have that history of her having 2 episiotomies. She's had all these like pelvic floor debridements due to her bladder swelling complication. So I'm getting that message, but I will definitely get additional study. So this is basically my conclusion from reading this. And so I'll go ahead and get a defecography. So just to orient folks, so to the left side of the patient, that is the posterior or the coccyx, and the right side is anterior. She had that hip replacement, so that's what you're seeing at the top right corner of the screen. She has some contrast in her vagina, which we are seeing on the right lower screen side of the screen, and the angle between, or the space between the vagina and the rectum is something that we sometimes look at to determine what the pelvic floor is doing. But for the purposes of this case, we're just going to focus on the rectum and the anus or the anal canal. So this is when she squeezes. And so you can see from the left picture is when she's at rest, and then the right one is when she squeezes. And I wondered, Dr. Rosen, if you want to discuss or pause to have a discussion about this, what people are seeing.
Sure, absolutely. So I certainly am not the best at interpreting these. Why don't we go back to Dr. Vogler, and since she looks at these on a daily basis and can tell us what you're seeing, and then we can even, why don't you keep it in this view, Steve, and then we can go, there's a video on the next screen. So Sarah, why don't you walk us through this?
So when you go from a resting to a squeeze on defecography, it's helpful mainly to see if they can move their pelvic floor. So if you want to see it pulled up, so their anal rectal angle is going to go to whatever baseline measurement you have to a more acute angle. So it should drop, literature is variable on this, but say 15 to 20 degrees from your baseline. But like I said, the biggest thing is to see the pelvic floor move up, just so that you know they have the ability to squeeze in and move their pelvic floor. And then after that, I normally have them go back to a rest and then start to evacuate.
So this is when she strains. And Steve, could you start the video again, since it goes so quickly? So if you pause it and then you drag it back. So she's pushing. Okay. And again, just to orient folks, so this is clearly, this is her, the right side is her vagina up front, and then we're looking at contrast emptying out through her rectum and her anus down there. And then you can see still she has a little bit of an angle, her anorectal angle is still present. But I wonder if folks want to comment on what this tells them about her function. How well does she do with evacuating the contrast? Do you think this supports what the anorectal manometry found?
Hello, my name is Radek. I'm a student with Dr. Ragua, and did have a question. Could it be, given her extensive surgical history, a result of postoperative adhesions that just took a while to form?
That's definitely a good question. Yeah, it definitely can. And that could maybe explain some of the inconsistencies that we are seeing in terms of the testing results, but definitely.
Steve, why don't you go to the next slide? I think there's a good still comparison picture there. And then, yeah, here. So this is where Gifty was talking about the change in anal rectal angle here. You still see an angle there. You see going as the rectum comes from the top left of your screen to the bottom right, and then it goes to empty. There still is that angle. It doesn't straighten out maybe as much as you might see. I learned that after consulting with this case with Dr. Vogler, and she taught me what that means. But so I think that's the main thing that we're getting at here. And so let's bring it back out to the discussion view here, Steve. So now we've got this constellation of findings. And then, so now the question is, all right, so no more, we can't delay anymore. We've gotten all these tests. We have to actually do something. So I want to go around, I'll call on people. Let's figure out what we're going to do. Dr. Regenbogen, this has been a great case that Gifty's been presenting. What would your next step be here? Is it Are we looking at pelvic floor PT? Are we looking at medical management? What do you think, sir?
Yeah, I mean, I think here I don't have an operation in mind. And so if I don't have an operation in mind, I do think the pelvic floor physical therapy is often, my next move, because for a lot of patients, it's going to help. It's for very few, is it going to hurt? It may be a bit of a stall technique for some, but I think that would likely be the next thing that I would suggest.
Dr. Goldberg, I think you're on the line still. Are you able to weigh in and talk to us about how we can solve this very frustrating issue?
What I would do in this situation is send this patient immediately to Dr. Vogler, seeing as this is not my area of expertise, but I love your presentation. Let's hear the answer, Sarah.
Excellent. Okay, so let's talk about a few other options. So I think most of us would start with pelvic floor physical therapy, trying to get this patient to work and re-coordinate their muscles. Is there any other, Dr. Wexner down in Florida, do you have any other tricks up your sleeve you can do after pelvic floor physical therapy if this patient still has symptoms?
Number one, I've got two really good tricks up my sleeve. The left sleeve is Dr. Sands. The right sleeve is Dr. De Silva. I've got two people to whom I handed over the physiology lab many years ago after leaving Dr. Goldberg. But in all seriousness, I missed the very beginning of the case. I've seen all the studies, but what are her actual symptoms? Because that would determine what I do after physiotherapy fails, which it undoubtedly will. What are her actual symptoms?
Her main symptom is, go ahead, Gifty, sorry.
Yeah, so she's been having constipation, sensing of incomplete evacuation when she goes to the bathroom, but she's also having fecal incontinence. So she's having constant fecal incontinence, can't go to the bathroom, pooping twice a week, spending about 2 hours in the bathroom before she's able to empty.
You're muted, Dr. Wexner.
Sorry. The incontinence is a curveball, because if it's just the pelvic floor dyssynergy, I mean, I would go for botulinum toxin. But given that she is also having incontinence, that's clearly not an option. I don't know if she's tried enemas, just getting herself on a bowel regimen with enemas to empty herself. That's another option. I'm not a huge fan of the Malone procedure, but potentially if somebody wanted to ultimately avoid a stoma, a mace for irrigation that way. But I'd start simple. I mean, I would just start out, if physiotherapy failed, then I suppose enemas. We're not labeled in the U.S. for sacral neuromodulation for constipation. I suppose potentially there's a role to think about if her incontinence was, like, say, a score over 12, could you try sacral neuromodulation on that basis and see, for which it is labeled, and then see if there's an offshoot benefit for her dyssynergy. But anyway, physiotherapy and enemas first.
Okay, so yeah, I think you brought up SNS, which is a great part, and so did Dr. DeRoss in the chat section. Dr. DeRoss mentions that the data suggests SNS is more for patients with fecal incontinence than constipation alone. Dr. Vogler, does SNS fit in this situation? How do you go about figuring out whether to put that implant in these patients? Do you just do it and hope it works? How do you guide that decision?
So I agree with what a lot of people have said, is that SNS in the setting of mostly constipation with poor pelvic floor movement is not going to be ideal. Most of the studies that look at it predominantly in constipation show at best maybe a 50% improvement, which is probably half placebo effect during their test phase. So I think the only way I would push them towards SNS is if I got them on such a strong bowel regimen that they were just having pure fecal incontinence, but they're having bowel movements every day. So I kind of highlighted the fact that their anal sphincter muscle is too weak. If I couldn't push them to the point of having bowel movements every day, possibly in worsening their fecal incontinence, then I would just stay away from an implant, because you'll get into this cycle of trying to program and reprogram and try to make it perfect. And it's just really not the setting that it was meant to work in.
A really interesting point you bring up about maximizing the therapy, almost pushing them to fecal incontinence and then solving the fecal incontinence with the SNS. how do we go about, a common question I think we all get from these patients is, well, you know, Miralax works for me, but Dulcolax doesn't. Magnesium works, but fiber just makes me bloated and painful and terrible. How do we find that best medical regimen? And Dr. Goldberg, maybe I'll ask you, in your experience, is there a magic? Do you ask patients to just titrate up different medications on their own? How do we go about figuring out what the best medical regimen is for these patients?
Dr. Rosen, as I said earlier, these patients are handled beautifully by our pelvic floor center. That's exactly, no, I don't deal with this problem. But anyhow, good luck.
Gotcha. Dr. Vogler, what's your magic regimen?
Well, Gifty and Lily probably have their own Michigan concoction that they could talk about, but I normally do start with Miralax, and I commonly hear, oh, Miralax doesn't work for me, which is kind of like saying gravity doesn't work. Like there's an unlimited supply of Miralax they can buy at Costco to get it to work. But if they're very against trying that, then I'll just move through whatever pattern, some magnesium or milk of magnesia, senna, whatever they're willing to try. I do tend to stay away from fiber, especially in women or the thin women, because it causes a lot of cramping and bloating and maybe increased frequency. It kind of worsens overall complaints. It doesn't necessarily help quite as much with the incontinence and regularity in that patient population. But so Gifty and Lily, what do you guys try?
Yeah, what's the magic Michigan regimen?
Yeah, I definitely agree with Dr. Vogler that many of the patients have already been like all around, Robin Hood's barn with the over-the-counter stuff before they even come to you. So very often you can make suggestions of every bowel medication you can possibly think of, and they've tried that plus everything off the shelf at like GNC and Whole Foods. So I agree. I think that Miralax is hard to beat. And I also agree with Dr. Wexner that sometimes the patients can really benefit from an enema regimen if one of their biggest complaints is the sensation of not emptying. Even if they are emptying reasonably well, sometimes just even the placebo effect, I guess, of the enema can help them feel more satisfied after a bowel movement. So,
any specific types of enemas, Dr. McGuire, that you're using? Is it fleets, tap water enemas? What do you do?
Tap water.
Okay. And how about we'll stay with you, Dr. McGuire and Dr. Kwakye. What about injectables? Dr. Wexner mentioned Botox a little bit. Is there ever a time that you would inject Botox? Some people talk about Kenalog. I know, Gifty, on your exam, there wasn't much tenderness over the levators. Does that guide your management for injectables? What do you guys think about that?
Yes, I think Dr. Wexner pointed out the difficulty in this case where she has the fecal incontinence. We're worried about her sphincter function. And so I wouldn't go with Botox for her. It's not all purely a pelvic floor. We also have the sphincter too that's having issues. So in this case, no Botox. If we didn't have the sphincter issue, the fecal incontinence, could have considered it, even though we didn't have any levator, ani sort of like symptoms. So that would be sort of my answer.
All right, why don't we go back to the presentation and talk to us a little more about how we wrap this up.
Okay, so actually her defecography, the radiologist also read it as having some internal intussusception, which is very difficult for Dr. McGuire and I because we are in this multidisciplinary setting. So the report goes to the GI physician or the urogynecologist. They're like, clearly there's a problem here, and this is why they're having the sensation of being unable to evacuate. So the patient gets sent back to us to do something about the internal intussusception. But, and the reason they call internal intussusception because there's a little bit of flattening of the rectum. I don't know if you can see, it's almost like it flattens out a little bit on the picture to the right. But if you go back to the video of it, you can see that when she pushes, she strains, and then at some point she takes a breath again, and then it goes away, it straightens up. And then when she pushes again, that's when you see that flattening happening. So I wasn't really impressed with the internal intussusception, but it does make it a little bit difficult talking with our colleagues because it's on the radiologist report. The patient also sees this, they do all their homework, and they feel like there's something there that we are reluctant to manage surgically. So I think we already talked about this. I think it's definitely difficult. Number 3 would not be something based on hair scan. I do have another patient who has clear intussusception, and I think some of her constipation or her fecal incontinence is probably due to some overflow process. So I think in that situation, we might consider differently. The next slide. So talking with the patient, I think how I've approached these patients is trying to figure out what their biggest concern is. For her, it was the fecal incontinence. So she had been on all these bowel regimens and had not been compliant because of the fact that she kept on having significant drainage. And so her GI doctor ended up trying to do Metamucil, trying to titrate that, even though she was having a lot of bloating with it. We did send her to pelvic floor physical therapy. And because she was having urinary incontinence along with the fecal incontinence, we did send her for consideration for a sacral nerve stimulator, even though we know in this situation that it might not necessarily help with her constipation part, but it will address her fecal incontinence.
Yeah, I was exactly, you caught up, I think, on the chat question as well. Dr. Duras asked that there's an increased incidence of history of sexual abuse in patients with chronic constipation. Do we routinely screen for this? And if present, does psychotherapy play a role in treatment? Gifty, what do you think about that in your patients? I'll say personally, I ask about, I do take a sexual history, but I can't say I specifically ask about abuse in chronic constipation. How about you?
Yeah, I have to confess that I don't routinely ask specifically about sexual abuse. In some select patient populations, I do. I think someone pretty young doesn't really have much of the other history, like the delivery, the vaginal episiotomies, other procedures on their anorectal area. Like when it doesn't really fit why this patient is there with symptoms this early on, I might dig into it a little bit deeper, but I don't ask specifically about sexual abuse in patients who fit the normal criteria. And Dr. McGuire wants to add on to that.
Yeah, I do ask about it specifically, and one of the reasons is just actually having a early failure of a ventral rectopexy, because I hadn't appropriately screened the patient for essentially repetitive sexual violence in their relationship. And I only was able to figure that out post-operatively, so that definitely changed my practice.
Great, and we're just about out of time here, so I'd like to wrap up. I think a really good point you made, Gifty, is that all internal rectal intussusception is not the same. You have to look at your defecography and compare it with the symptoms. If it's it's intussuscepting, if you have a large intussusception that doesn't relax and doesn't retract, I think that's very different than the question of one that you showed on this defecography, which I think goes to the importance, as we all know, of looking at our own studies. And if you don't know, like me, how to really read them, talking to someone that does know, they don't blindly do an inappropriate surgery. I think this whole presentation just shows how difficult of a problem this is, and how much interest there is in figuring out what's the solution. And we don't have the perfect magic bullet, but I think now, after hearing from everybody, I actually feel a little more confident with all my different tricks up my sleeve and things we can do. And I think this goes to highlight how great of a collaborative effort we can have to solve this problem. Before we wrap up, Gifty, any final thoughts or comments?
I was actually typing something in the chat. I just want to thank everyone again for coming. I think the main takeaway from today's session is, if you have a pelvic floor patient, just send them to Dr. Vogler, because that seems to be the running theme. But I think that's something we can do for these patients, and pelvic floor therapy definitely works. I think we should do the workup, make sure it's not slow transit constipation. If it is obstructed defecation, pelvic floor physical therapy, and then just go from there. But thank you again, everyone, for coming and inviting me. I really appreciate it. And it was great seeing old friends on the chat. Thank you.
Thanks for a great presentation. We will be right back here next week on Surgery Live. We'll have a pediatric surgery case. Dr. Cass is going to present a fetus with a right upper quadrant cystic mass with Dr. Duras and Dr. Alatoya helping to moderate. Thanks again for joining us, everybody, for a great conversation. We'll see you next time on Surgery Live.